as I explained to Paulette before we started recording, that maybe we should just start off with one slide that is introducing autism, and then in the subsequent training sessions we're going to expand on this model. Now, a brief introduction to the model. It was created by a lady called Donna Williams, who sadly passed away about 3 years ago now. And she started, she's diagnosed with childhood psychosis in '63 and auditory processing disorder because they thought she was deaf. And her diagnosis was confirmed by Dr. Bartek. This was in Australia in 1990. And then she started doing consultancy work. She started off with the 3 phases of autism, which was autism, Asperger's, information processing, and exposure anxiety, which I'm going to talk a little bit about today. And then she expanded it further into this fruit salad, which is that autism isn't actually what we're taught. It's a clustering of pre-existing conditions that are based in neurology and or biology. So when I talk about autism, I like to stick to facts, because facts are what people need when they are either diagnosed with autism or family members, parents, guardians, etc. It's all about looking at the facts, and then by looking at the facts, then you look at the pieces, and then by looking at the pieces, you're able to advocate for those pieces. So that's how I work as a consultant, that's how I work as a trainer, and that's how I work as a speaker. It's about giving people facts. So if people want to look at this model in their own time, what I recommend is you could go onto Amazon, and if you can see on the image, there's 2 books at the top Donna wrote called Autism, the Inside Out Approach, which is a very good handbook, and then a sequel, an updated version called The Jumbled Jigsaw. And you can either get, you know, physical copies, hardbacks, softbacks, or you can get, I assume, I hope anyway, ebooks, so electronic versions. And just before I go into this model, another really good thing she done in 2014 is she done a blog, What is Autism, which is ironically what this training is called. And if you Google Donna Williams' blog, What is Autism ? 2014, she's got a blog which expands on all these things. I mean, she took a long time, you know, compiling all the possible intricacies and differences that someone could have. So the first thing I would say about this training is it's effectively a myth-busting exercise. It's about getting to the roots of what autism is. So a brief historical aspect. The framework for autism has been changing for decades. So in the 1940s, it was thought to be an attachment disorder. So that it's all about frameworks. It's all about what people thought it was. So that was in the 1940s to the 1950s. Then in the 1960s, when Donna was diagnosed, one would be diagnosed with childhood psychosis. They thought, you know, that autism was a breakdown of reality. That's what psychosis is. And they were diagnosing childhood psychosis, believe it or not, until as late as the 1980s. That was a diagnosis that kept rolling on through the decades. In the 1970s and the 1980s, though, along with that being kept, people thought that autism was exclusively a form of mental retardation. Retardation, the word, the meaning of the word is French. It's retard means slow, so slowness. So they thought it was a form of slowness, a form of intellectual disability, cognitive disability. And then and that went into the 80s as well. Then in the 90s, we got the introduction of Asperger's syndrome in the DSM-4, and the other one overseas, the ICD-10, I think it's called, where you had autism spectrum disorder and you had Asperger's syndrome. And of course, Tony Attwood in the mid to late 90s wrote a guide to Asperger's syndrome. So you can see quite clearly through decade to decade things are changing and moulding. Then in the noughties, you've got about sensory issues, so sensory integration issues, sensory perceptual issues. Now in the tens, what you're getting is metabolic disorders, autoimmune disorders, tissue connectivity disorders. I'm seeing a lot of people getting diagnosed with hypermobility and Ehlers-Danlos syndrome. I'm seeing it a lot. And Ehlers-Danlos syndrome, I could do a speech on that all of its own because it's a very complex condition. There are different types where it can affect joints, and what else is it? Melanin, the tissue that connects everything in your body. You know, that is the great binder of everything, and then it can cause problems with skin, rupturing of organs, to the type 4, which can be very disabling, where you have vascular issues, veins, heart, and Donna had type 4, and she had apnea as a result of EDS type 4. So you can see that there are even expanding every decade as it has given its own view, its own framework of what autism is. A lot of it was wrong. I'll have to be quite honest about it. And in the next 50 years, what I'm saying will be dated, antiquated, because it would have moved on further. So you get an idea of what I'm trying to say here, that a lot of what you hear about autism today is inaccurate. And I'm not saying that to be rude, and I'm not saying that to hurt the people who are trying to advocate. What I'm saying is that if you really want to know what autism is, sometimes you have to take some of the emotion out of it. Not all, because it is emotional. It can be an emotional subject, particularly if it affects you or a family member, but you can supply facts with empathy. It's something I've said before. It's about giving people the right information, or at the very least, allowing them to find the right information. I hope that makes sense. That's what advocacy is. That's my view. It's about supplying information in a holistic, truthful way, which is about empowering people, not enabling, because enabling implies something completely different. It's maybe not the best use of the word. At least with empowerment, you're giving someone the tools. So the first aspect of this slide I'm going to talk about is information processing, and that is to do with the brain, the nervous system, and biology as well. It's not just the brain. There are other organs involved with information processing, and it can affect to varying degrees. So there's a list here which I'm going to go into. And before I made an error with the EDS, not melanin, that's pigmentation. I want to correct that error. It's collagen. Collagen is the binder. It's the glue that binds things. I just want to correct that error, because but why would a pigment of skin affect binding of the body? It wouldn't. So I just want to correct that. It's collagen. So now this list. So the first thing there is sleep disorders. So already you're seeing a clustering of things. So if you imagine autism as a specific stacking of different things for that person, that's a good start, because some of the things I'll say will be irrelevant, and that is fine. So sleep disorders. Sleep disorders can be to do with chemical imbalances. It can be to do with overthinking. It can be to do with the inability for the brain to get what we call REM sleep, rapid eye movement sleep. It's the ability to go into a deep sleep, which some people on the autism spectrum and off struggle to do. I met one young man whose parents explained when bedtime came, he would think about the day. So it's almost like he had this backlog of processing, which he had to get through until there was an endpoint, or at least a perceived endpoint, so then he could get to sleep. But then there's chemical imbalances, ADHD. There may be other diagnoses, other conditions impacting on the ability to just get to sleep. And that's the next one, attention deficits, ADHD, ADD. So that's the ability to focus. So that is, I suppose that's two things you could put under cognitive and learning. And socializing. It affects all three. The ability to focus, the ability to actually compartmentalize, the ability to actually look at things and taking what you need and nothing else. So then you could kind of say that there could be some remit for executive functioning, the ability to juggle different aspects. Then you've got learning disabilities. Now, learning disabilities, I know in the UK, means someone with an IQ below 70, which is awful. I don't like it. But I think what Donna means is learning, what we call learning difficulties in the UK. So that can be things like dyslexia. So dyslexia is to do with a mixture of things. It's not just one thing. So dyslexia can be to do with how someone writes, which goes into dysgraphia. So they can actually all mold and ebb and flow. How someone writes, when they write, it can be fluctuations in style. That's a problem I had. Words can be going big or small, so they could start off really big and then get really small, etc. Punctuation could be non-existent or put in the wrong places. Paragraphs may be quite distorted, so they might be just a big chunk of text with no paragraphs. What else? I suppose it's the way one learns to write as well. That has to be taken into account as well. And how someone builds a framework, mentalizes what they've got in their head and how they translate it onto paper or on screen. Then you've got dyscalculia, which is, I suppose, in the most simplistic way, it's like maths dyslexia. So all the problems I extracted in dyslexia can pour over into maths. So symbols, numbers, calculations. I had a terrible time at school understanding even the basics. And then when we got on to, more complex divisions, more complex times tables where you're actually using, rather than just, tens, you're actually going on to hundreds and thousands, and then that would I completely lose the thread of how the numbers could be divided, and then all the aspects of doing that, even though the teacher was explaining as well as they could, it's effectively about how you internalize information, how you process what you're seeing. And then you've got dysgraphia, where it's actually problems with holding a pencil or a pen. And I know that's becoming less and less of an issue with technology, but certainly with me, they tried putting a rubber kind of triangle on the pencil to try and make me write properly, because I was meant to pinch the pen or pencil, but I write like this with the thumb wrapped round the finger, and it's stuck. It's always been the same. So learning difficulties or disabilities can go hand in hand with cognition and learning. Now, we get into some more complex stuff, and I'm just going to give you a basic overview of these three words. So the first one is agnosia. So all agnosia is, in the most simplistic way I can describe you, the sensory organs work, but the perception, the awareness of it doesn't. So common agnosias on the autism spectrum, which I'll expand in the later training, are face blindness. That's a common one. The inability to recognise people by their faces. And that can cause challenges around bonding, around friendships, and it can cause, obviously, problems with self-esteem, problems, well, being in a room with people you don't recognise means that they may do compensatory tactics, which are good, to recognise the person. So it may be that they have a familiar pair of glasses on. It may be that they have a gait that they recognise. It may be that they have a voice that is quite recognisable. So you can see that the person's eyes, the sensory organs are working, but they're not perceiving or seeing faces. The next one is agnosia, which is object blindness, which is what I've got, and one of the reasons why I wear tinted lenses. So that is the inability to take incoming information and see it as a whole. So you see bits of things, not wholes. So it's all distorted and fragmented, and that can affect, well, it can affect learning. It can affect the ability to mentalise, because if everything's in bits, how do you get a coherent view in your mind's eye? It can affect travel. It can affect the ability to socialise and get self and other. So self and other is something that non-autistic children learn about 5 years old and as late as 7, 8 or 9. And it's the ability to do a shared sense of social. So this is me, and this is you, and this is you, and this is me. And it goes in a circle. It's called shared sense of social. And some people on the autism spectrum, personality types aside, struggle with self and other. So they can either do all self, no other. This is my thoughts. I can't take in the patterns. Or they can do all other, no self. So I'm taking in the patterns of the person, but I can't integrate my own thoughts, feelings, or verborosity. Do you see how that works? Does that make sense? And it can get misunderstood as being lazy, non-compliance, not listening, being narcissistic, dominating a conversation, etc., etc. But it's an information processing challenge. So agnosia may be is an extension of visual perception. So visual perceptual disorders. The next one, which is common in Asperger's, is social emotional agnosia. And social emotional agnosia is the inability to see body language, facial expression, or tone of voice. So if you can't see those two things and hear that one thing, all you can hear and see is facts. Think about it. If you can't see body language, you can't see facial expression, and you've got a tonia, you can't hear tone of voice, all you hear is facts. So quite rightfully, even, let's say, emotions, it's not a devoidance of them, but the understanding of them, maybe the way in which you need to supply emotions as just an example, is to set them out in a concrete, factual, list-like way for the person to integrate them. The reason why I don't see body language or facial expression is a completely different reason. It's to do with visual perceptual disorders. Social emotional agnosia comes from a different part of the brain as visual perceptual disorders do. So that has a massive impact, firstly on experience, how someone is experiencing that, and secondly, how you find ways of, I suppose, alleviating the challenges by looking at what it is specifically and then going from there. Do you understand what I meant earlier on in the training where I was saying about facts? Alexithymia is the final one I'm going to finish on, and that affects about 80% of people on the autism spectrum, and that's to do with not knowing one's own emotional states. So not knowing one's own emotional states, their own, means they may struggle to process information. They may, emotional information, how they feel about something. Going to events like funerals, for example, they may have a delay. I remember when I went to my aunt's funeral, it took about 6 months for me to be aware of how I felt about it. I used to think my emotions came from another place. They didn't come from me. It was this external alien thing. And I would self-harm because I would get so overwhelmed with this barrage of emotion that would drip, 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 and then just slosh all over me. And then I would become emotionally overwhelmed and overloaded. And then I would harm myself as a way to dampen down the overwhelm of my own emotional state. So that's just an example of how that could work. The next one is Praxis. So that's all to do with movement. You can get motor coordination problems, so you can get fine and gross motor coordination. Some people may even have a formal diagnosis of a coordination or movement condition or dyspraxia, and that can mean that the person is more prone to overload because they're having to consciously think about their movements and how their movements work within the environment. And that can have an effect on confidence, self-esteem, and lots of other things if you think about it. The next thing is aphasia, and aphasias come in different degrees. But effectively what an aphasia is a language processing disorder of varying different types. So for example, when I was younger, I was about 80 to 90% meaning deaf. I would have been diagnosed with severe autism if I'd have got a diagnosis in the late 80s, early 90s. I appeared not to hear or see anything. And it was nothing to do with the sensory organs. It was to do with how my brain was juggling, processing and perceiving this information. So if someone's got a high level of meaning deafness, it's got nothing to do with a lack of intelligence. It's to do with the brain's ability to take in verbal information. So you may need to think of more inventive ways, and trial and error is good. I often say failure is my friend. Failure is a normal stepping stone to trying to succeed, rather than looking at failure as the ultimate barrier. So for some people, you may need to truncate and simplify language. You may need to allow time for the language to sink in. You may need to use gestural language. So you may need to marry up your words with gesture. You may need to use objects of reference. You may, if they are a visual thinker and visual processing, just by the way, visual processing is one of the most common forms of learning. It's about 70 to 80%. So I just want to myth bust about that. Not all people with autism are visual thinkers or visual processors or mentalize visually. There's different ways of mentalizing. But if it works, it works. And if it aids in association, because if someone is meaning deaf and meaning blind, that would make sense that they're not making visual verbal associations. So if they can't make those associations, then it's about finding a way to build up a framework which they can understand. So now we go into the biology. So gut immune and metabolic disorders. Gut immune and metabolic disorders can, in the most simple terms, cause pain. And pain is going to affect information processing. Pain is going to affect the way the person views themselves. Pain is going to affect association. Pain may mean, in the most severest forms with some of these conditions, they are in and out of hospital. Being in and out of hospital means there's gaps in development. Being in and out of hospital means that they get an association with their childhood that maybe be considered quite foreign and quite unusual. So it's not just the factor of pain, it's the environment that they're in because of the pain, which then can affect development, which then affects association. So you have to look at the psychological effect on a child if they're in and out of hospital for long periods of time. So gut immune and metabolic disorders can range from mild to severe. And when I mean severe, they need interventions, which means hospitalization. Cellular and collagen disorders. I mentioned about Ehlers-Danlos syndrome. So if someone has cellular and collagen disorders, so that means that could go as far as having gene deletions and other things like that. My father has a gene deletion. He had leukemia. He's on the autism spectrum. And the gene deletion he had is called P53. And P53, if you imagine a protein sticking to cells, he doesn't have that. So he doesn't have that protection. It's called the guardian angel gene of cancer, right? So if we're going to talk about autism, let's talk about the whole thing. There are some people that go through life with autism that just have the neurological conditions. There are some people that have medical autism. That isn't me being controversial. There are a lot of studies that some people on the autism spectrum live with autoimmune, metabolic, and gene deletions, which means that they are, in simplistic terms, immune suppressed. Their immune system is not working as it should be, and it's effectively having the immune system of an elderly person. That's the most simplistic way I can give it to you. My father is on 60 tablets a week because of being immune suppressed. And one side, it's really interesting how his body's reacted to being immune suppressed. If you can imagine your lungs and being with COVID, it's quite traumatic. His fascia is hardened and gone up by an inch. So your diaphragm allows your lungs to breathe. They done a scan on his diaphragm and one side does not work at all. So he's only got one functioning lung. So, and that is because one side of his diaphragm, because of inflammation, has gone rock hard. There is no movement in that whatsoever. So those people, like my father, like Donna, who documented about her immune problems, need to find a specialist who is open-minded enough to not just view autism as a static two-dimensional thing, but as a three-dimensional thing where other factors come into play. That is the best advice I can give you. Then you've got seizure disorders, so electrical activity in the brain, and that affects about 70 to 80% of people on the spectrum, which is a lot. And then you get mild brain injury, and mild brain injury can be to do with all sorts of factors. It could be to do with hypoxia or something happening after birth. For me, I had cerebral hypoxia, so I had a traumatic birth, and part of the traumatic birth meant that mild brain injury is just simply part of my autism. It's not a part of everyone's because autism is different for each person, okay? So that's a basic overview of the information process, and it gives you an introduction. If you want to look at this in more depth, you can look at my blogs and Donna's blogs. The next aspect is psychiatric comorbid. So this is mental health. 70 to 80% of people on the autism spectrum are thought to have mental health challenges. And there was a time in the 80s where they thought people with autism were incapable of having mental health problems. Everything was the autism. So we've changed a lot in the last 20, 30 years. So some people with autism can have mood disorders, emotional dysregulation. In fact, emotional dysregulation is common in autism. It's about 60%. 60% of people, for whatever reason, whatever origin, struggle with the ability to manage and function their own emotional states. Then you have anxiety disorders of varying different types and degrees. There's a 30% overlap with obsessive compulsive disorder. You can have generalized anxiety disorder, and you can have social phobia or social anxiety disorder. And you can have a whole array of other anxiety disorders which compound the presentation of the autism, but a layman may think that's all to do with the autism. It isn't. Psychosis. Someone with autism can have psychosis. Psychosis isn't autism. Psychosis is a breakdown of reality. I had psychosis. The way psychosis presented with me, that was about over 10 years ago now, was auditory hallucinations. And auditory hallucinations or visual hallucinations are compounded with the psychosis. So psychosis is your senses working in a detached way. If someone has psychosis with autism, it's imperative and absolutely important that you unpick that it's psychosis. Because then what you can do is then once you get an idea of what something is, you look for ways of helping, empowering, and ultimately making that person balanced. Balanced is a subjective word. I'm not saying make them non-autistic. That's not what I'm saying. In fact, that's the opposite of what I'm saying. Being balanced is a right that every person has. And if they have conditions like this, it's worth knowing. Because if one spent 20 years being told it was just the autism and actually it wasn't, that's a great disservice, don't you agree? The next thing we've got is impulse control. Now, I've seen many classrooms where people have impulse control. So they're picking their nose, they're picking their skin, they're plucking their hair, they're scratching and picking, and people wonder, why do they do this? What is going on there? Twirling their hair, and impulse control can be very difficult for some people because they don't know they're doing it when they're in the act of it. So some triggers for impulse control can be anxiety or uncertainty. I've got a condition called Dermatomania, which is skin picking, and I pick my head and get a nice juicy scab, and it comes delicately out of my scalp. And while that is happening, I have no awareness it's happening until someone says, Paul, you're doing this. Do you realise you're doing this? I've seen, I've seen one chap, go around his backside and pick round his anus and then come out and smell. And at that moment, people go, oh, that's disgusting. And you get all this emotive stuff, don't you? Oh, I can't imagine someone doing that. Well, guess what? You've just seen someone do it. Let's understand why they're doing it. Why is someone going through impulse control? A friend of mine called Sydney, I use this example a lot because I think it's amazing power of the conscious and unconscious mind. She had some dental work and she had to be put out. And the dentist done the operation. And when Sydney came round, the dentist said, do you realise, Sid, that when you were under, you were still twirling your hair? So it's an so that suggests that impulse control is an unconscious act. It's not a conscious act. So they switched off the conscious mind for the dental extraction, but the unconscious mind kept doing the impulse, right? So that's very interesting, that correlation between the conscious mind and the unconscious mind. The next thing is attachment disorders. Now, of course, this can be a tricky subject because that is what they used to think autism was. So it must be very tricky if both is going on. And attachment disorders generally are to do with the inability to bond with one's mother in the first half year of life. And that can be very difficult, and there can be very, very complex psychosocial aspects to this. So if someone has an attachment disorder and a developmental condition, yes, that is very difficult to unpick. And it can also, get misinterpreted for one or the other, which can be, of course, quite dangerous. I want to be quite careful with this because I have heard in some constituencies, some GPs, I'm not going to name them, it's just something that I've been told by a few parents, that they imply or overtly say that this isn't autism. So I just want to be very careful that if an attachment disorder is happening, and I mean is happening, that is what is going on along with the autism, then of course that has to be looked at, because that has a lifelong effect on the development, a lifelong effect on emotional resilience, a lifelong effect on association with parental roles, and also association with the world. So it can cause trauma responses. That means, in most simplistic way, is that that person as an adult, without having these things looked at through their childhood and adolescence, actually become an unbalanced adult. And an unbalanced adult is more likely to go into substance abuse, more likely to have problems with relationships and friendships, more likely to have personality disorders, more likely to have quite a difficult life. So it's about understanding, again, the facts of the situation to help these people. Dissociative disorders. So dissociation is common. In fact, normal forms of dissociation are daydreaming. We've all done that, haven't we? And dissociation is a normal part of childhood development of imagination. I'm sure you can remember being a little girls and boys imagining you were in magical lands or in different places. That is the breeding, the normal, the normal, I suppose, foundation, stepping stones of the fruition of human imagination. And where dissociative disorders become more complex is when they become, I suppose, a disorder. One reason why I dissociated was because of language. It sounds so trivial, but I found interpretive language so peculiar, so odd, that I would just switch off from it. So dissociation can be depersonalization, where you dissociate from yourself, and then you can get derealization, where you dissociate from the environment around you. It's a defense mechanism. And then extensions of dissociation can go into rounds of PTSD, dissociative coma, dissociative fugue, where they have lapses in memory because there's pockets that they've dissociated from, so there's lapses in memory. And then extremes where you get dissociative identity disorder, where the person creates different identities that have their own characteristics, idiosyncrasies, verborosity, etc. So hopefully that gives you an idea that not everything is the autism. In fact, there are other things with the autism that compound it. And if some of those things go away, one may be prudent to say that they're less autistic. Well, it's because what you were seeing wasn't the autism in the first place. You have to almost reverse the narrative. It wasn't that they're less autistic. It's just that something was there not to do with the autism that's been alleviated. You must, if you go back in your own personal lives where you may have had depression or anxiety, you don't function the same. You don't. And you're different. And the reason why you're different is because your brain chemistry is imbalanced. That's the most simple way I can describe it. So it goes on nicely to identity and personality.
Paul, 10 minutes, Paul.
Thank you. So
okay.
Identity and personality is what all human beings have. It's one of the things that's missed in autism, because everything gets called the autism. But human beings have 4 to 6 different personality types with different sensitivities, different ways of viewing the world, different ways of learning, different ways of interacting that are specific to the person. Identity is also important. How does someone view themselves? Male, female, gay, straight, bisexual, pansexual, non-binary, etc., etc. That, if we think about that, human identity has a massive thing to do with development and how someone views the world, and not only how someone views the world, how someone views themselves. It's a very important part of development. So if anybody wants to expand on this further, because that is a massive topic, which I'll be going on to in more depth in later training, I recommend a site called P-Types. And what P-types is, it gives you all the different personality types and their disordered extremes. So for every personality type, when frequency goes up in life, stresses, etc., it can swing into disordered extremes. And disordered traits then affect behaviour and ways of functioning. So that's something to think about. The last part is environment. And that's very important. The environment of a human being, you could argue, is the very essence of how a person, a little person, starts to build up associations with the world around them. So environment, diet and nutrition. So if someone's going to school with dietary disabilities that are causing pain, that are causing discomfort, that are causing brain fog, so the inability to take in information, that's going to affect functioning. Mourning the child. If someone mourns the child, I'm not going to judge parents or guardians that mourn the child. Chronic mourning means that, you know, maybe the parent needs to go into counselling or speak to a friend or get some help, because what happens is, what parents should never feel ashamed of this, of having a framework of how a child will be. You know, you imagine how a child will be before they're born. And then what happens is you have to replace all those expectations with what's happening. And for some people, they live a grief. They grieve for the child that they haven't got. And that is a very important aspect, because that needs to be recognised, not judged upon. You know, if the parent is very worried about saying, well, actually, I've got these feelings and I don't know if they're quite right, can I talk to someone about this, please? I think it sounds almost cliched, but talking and expressing in a balanced environment where you know that your words are not going to be judged. Your person isn't going to be up for the chop if you start saying some of these thought processes that you're feeling. The next aspect is isolation and alienation. I can tell you now that they've done studies in prisoner of war camps and other aspects of extreme isolation and alienation. Do you know how long it takes for the brain to react to this phenomena? It takes only 2 hours for serotonin to deplete when someone is isolated. That is an amazingly short period of time for the brain to start reacting. So you can imagine chronic isolation, chronic alienation, how that is going to affect the person's mood, the person's identity, the person's drive. Learned helplessness. So some people learn to be more disabled than they actually are. And this can be to do with lots of factors that I said above. Dependent personality disorder, someone who has learned to be codependent with someone. And codependency is very complex. So the martyrdom of the teacher or guardian or parent constantly seeing the world as a threat, and not only seeing the world as a threat, perceived threats means that the person has to be safe from them all the time. And that means functioning can become lower because the person is getting in a loop of codependency, the martyrdom of the saviour to the scared person who can't do anything because I've got someone else to do it. Do you see how that cycle goes? And it's a very interesting phenomena, and it's completely understandable. The world, to some degree, is ill-equipped for disability in many areas. So it's quite natural that one would react in such a way where they would actually, anything is a threat. So it's almost like hypervigilance. If everything is a threat, I am not going to let my son or daughter have the burden of feeling those threats. The problem is with doing that, it lowers resilience. And it lowers resilience to the point where they may not know how to cook, clean, put their shoes on, and do all sorts of things they're actually functionally able to do, but it's been taken away from them. And also we have to look at the psychology of the parent or the teacher. Why are they doing this? What do they know they're doing it? They may not know. They may be so in the loop that they don't actually know that this is going on. Presuming incompetence. Some of the people who would be called more severe, who I've worked with, it's not to do with a lack of intelligence, but how we see and view intelligence as having a look. I've worked with people who have been written off with low IQs. I remember working with a young man with Fragile X syndrome. And if he got an idea that you thought he was stupid, he'd run rings around you. He's very clever. And I remember him, I remember going down into the kitchen, and there was Bob. I'm not going to name him, but that's his other name. It's not his real name. And I looked at him, and he looked at me, and he started to giggle. And here was this bloke in the kitchen doing everything for him because he presumed he couldn't do it. And Bob had this little twinkle in his eye, as if to say, look, he thinks I can't do this cooking. I will allow him to think, I'll allow this gentleman to think this, so I can just stand and watch him do it for me. So presuming incompetence, I mean, that's obviously a funny side of it, but actually for Bob, at times it's incredibly frustrating if people view you in a certain way. Never presume incompetence. And I'm talking about specifically the people who are functionally non-verbal, the people who get diagnosed with severe learning disabilities in the day centres. Never, ever presume low IQ, because all that is a very static, linear way of judging someone's intelligence. It's completely dated, and I don't know why they use it. Partly it's funding, I know, but let's look at these people in a different way. Cat people versus dog people. So you get the cat people who may have, the pathological demand avoidance, the exposure anxiety, where you have to be indirect. These are people that struggle with the directness of communication, and their nervous system negatively reacts to it. So you may need to reverse what you're saying. Humanize objects. The TV, I've got a TV over there. The TV would like to be switched on. The shoes would like to be tied. The car is ready to be boarded. The pan is ready to be tended to. So what you do, you focus on the object, not the person. Works with PDA as well. So you focus on the object, not the person. You don't strike up their nervous system, so that, what you're effectively doing, you're working parallel with the system. Cellular gut and brain injury, well, of course, that is going to have an effect on process and environment. And eating toothpaste, people laugh at this. They think, oh, so these people that have pica, who are guzzling toothpaste, well, I'll give you a clue of why that is absolutely destructive. It's got fluoride in it. Fluoride breaks the blood-brain barrier. It can cause a lot of damage, and fluoride can cause gastro and intestinal problems. So what it can do, it can wreck the lining of the stomach, wreck the lining of the intestines, and you've got someone who has stomach ulcers. Well, imagine if they're functionally non-verbal, and how do you begin to describe peptic ulcers? I mean, I've heard it's absolute agony, because it's the lining's been destroyed and the acid gets in between. It's very painful. So eating toothpaste, although sounds quite humorous, I remember working with a man about 10 years ago in Aylesbury who has schizophrenia and learning disabilities, and they used to give him strawberry flavoured toothpaste. Well, he used to just put this in his mouth like it was, food. And every morning, he would get up with a stomachache. And now I realise that potentially why that was happening is because he was ingesting copious amounts of fluoride, which in turn was damaging his guts. So there's the last thing I want to say is learning styles. That's the final bit. One could argue the most simple bit. That's why I've left it till last. But learning styles, all human beings are different. So you have visual learners, logical, pragmatic learners, verbal learners, oral learners, listeners, physical, kinesthetic learners. And then you have different types of learning on top of that. Is someone a social learner? Does someone like to learn in groups? It's about getting the most out of one. Is someone a solitary learner? They actually like the preference of quiet or having a certain routine where they're on their own. Or some people who like a mixture of both. I'm probably both. It's about how much I can take of the group, but then I can go back to being solitary. So I hope I might have time for questions, which I do. I think I have about 5 minutes. I've really enjoyed doing this. This is a basic overview, which I'm going to expand upon, particularly the information processing in the later training sessions. I understand if some people are a bit overwhelmed by this, because for some people, this is completely new. But I thought I'd start off with one slide, just one, because as you can hear, it's taken a long time to